Okay, hi all. My name is Lisa Stoddart Millingen. I'm an occupational therapist in Jamaica. I have a private practice. I see mostly children on the spectrum, varying degrees on the spectrum, and other neurological conditions. So, Therapy Plus is a center that has a kind of a multidiscipline team. We have behavior therapy, occupational therapy, we have a couple of psychologists on board. We have educators. And we also have a full time school program that we've started. We have about 18 children at present. But it's school, yes, but it's more of what we would term as an early intervention program. So when they're first diagnosed, we take them in and they're here 6, 7 hours a day so that we can get the best early intervention that we can before putting them out into the school setting. So today's topic is sensory integration, as said. And what is sensory integration? All right. So really, this is how the brain deals with processing of sensory information. So we receive sensory integration from our vision, our nose, our mouth, our ears, and our hands, as we know the common ones. Those are the five senses, as people know. However, there's two more senses, which are our proprioceptive senses and our vestibular sense. And these are a little more difficult to detect, and they give us a little more information to the brain about the body, but they're internal. So it's not like I touch something and I know that I'm going to touch it. It's a lot more subtle. Like the proprioceptive system has to do with your ligaments and your joints and the feedback to the brain about how those operate in unison with your body. So basically I'm walking and that's what's really keeping me upright, the vestibular system and the proprioceptive systems that are feeding back to the brain about where my muscles are, my antagonist versus my front muscles versus my back muscles, how that keeps me up, and where my head is in space. So if I put my head upside down, my body tells me, whoa, this doesn't feel right. Those are your vestibular and proprioceptive systems. So let us talk a little more detailed about the vestibular system. It's found in the inner ear, and this processes how our body interacts, as I said, with gravity and movement. And it coordinates our eye movements with our head. So it will affect things like copying from the blackboard, or being able to hold your body still while you're looking at something on a screen, going left to right on a page. So when we talk about these systems, we always want to think about the things that they affect, that if they're not right, you will start to see these things play out in the child in their ability to do tasks, right? It affects our balance, equilibrium, coordination. A lot of times when we get kids, one of the big parts of our program is a gym, and the parents are like, what? I need my kid to talk. But the thing is, if your body is receiving the senses inappropriately, then your output is not going to be correct either. And therefore, we have to do whole body work as well very early. And a lot of the children you'll see come in and they actually do kind of do that duck walking thing, and they're quite uncoordinated. And then within time, and I even get that. And beside the referral to occupational therapy, there'll be a referral to physical therapy because something's wrong with the way they walk. But oftentimes it's not anything to do with a physical problem. It's just the processing of their vestibular and proprioceptive systems that is affecting them. Okay. Now that was vestibular in a nutshell. The proprioceptive system, it's based in the muscles, ligaments, and joints and nerves that serve them. The proprioceptive systems are tell you all the time about where your body is in space. So where's my body? So for example, I'm going to go down steps. You don't sort of hold the wall and put out your foot and go down and then step and then think about the other foot. It just happens automatically. And that's because your proprioceptive system is constantly giving feedback to the brain about where your body is in space. And again, when that goes wrong, we have a whole host of problems, even down to the subtle thing again of being able to sit up in your classroom, hold your body up against gravity, stay focused while so children that have impaired proprioceptive systems have a hard time with their body, and then therefore everything else becomes so exhausting, trying to listen to the teacher, but really they're just trying to hold their bodies up or stay, keep their bodies together so that they can then hear what the teacher has to say. And I skipped quickly over the other five senses, but of course they are critical and they all work together. So for example, if I'm going to write something on a page, as when I write a letter, I have to, my eyes have to coordinate with my hands, with my proprioceptive system. I have to see where it goes. That goes back to the brain. The brain tells you, okay, here's how much space you have. And then the proprioceptive system tells you how much pressure to put. And you really cannot do them independently. There's no part of your body that can work independently anyway, but these all seven senses are completely interrelated to each other. I could probably talk for about 2 hours on the air and the inner air. The air is so critical. Hearing is critical. Again, when we first get early children and they're sent for hearing tests, we know they can hear, but what's really the connection that's missing is a processing of what they're hearing going to the brain for the brain to interpret, right? And so, when we start therapy, we have to be thinking about all of these senses: eye-hand coordination, the hearing, even their sense of smell, which can be throwing them off all day long if they don't like the smell of citrus, or, taste, it affects eating. There's just so many things. And when we do treatment, we can actually be doing things like chewing crunchy things while we are following a ball. Because what we're trying to do is to get the mouth and the taste in coordination with the eyes and the hearing and all of it working together. So when we do treatment, we try to use 2, 3 senses at one time to try to get the body to coordinate and integrate the senses. Okay. Good. You just see. Right. Okay. Can I get a little feedback? Am I being heard, Christy? Is everything going okay? One second. So if anyone wants to just type in the comment box, okay, great. I'm going. I'm on. Okay. All right. Fantastic. So, all right. So what does this all mean? What it really means is that we take in all of the senses from our environment: our eyes, our ears, our nose, our proprioceptive systems. And when you watch a young baby who is typically developing, you're amazed. You're like, oh my God, he's sitting up and now he's walking, and um, you say something and he turns his head because he's going to move his eyes in relation to what he heard with his ears. And you'll see that typical development definitely is completely dependent on the sensory system. Okay. And what we have discovered is that when the sensory system is faulty, as in what is going up to the brain for interpretation, then the output is going to be faulty. Okay. So let's take a child who is under some bright lights, and to you and me, we might blink and go, "Ooh, that's uncomfortable." But for the autistic child, that is excruciatingly uncomfortable, because his processing of that information is way too intense, right? So what happens is that it's faulty going in, and then his output might be, to avoid the classroom, or it might be broadcast keeps getting interrupted. Okay. All right. Can you keep that feedback coming if the broadcast keeps getting interrupted, please? I'll keep going, and if it keeps happening, you could tell me, and then I'll see what we can do. So if the input is faulty, then the output is going to be faulty. So the child might exhibit behaviors, or the child might avoid things because they just can't take the stimulation. Okay. It's the same with noise. The common one is that our kids on the spectrum cover their ears, correct? And again, that is their inability to process properly what's going on with the noise in the background or a blender, and then that goes up to the brain for processing, and the brain doesn't process it right because the input was incorrect, or the input does not come in the right way, and then the child might scream and freak out, and so their output is also impaired, right? Because now they're going to do all these things that you you don't want them to react in that way, but they can't help it because their sensory system is driving them to do that. Are you still getting interrupted? I had my phone on. I turned it off. So if we have a normal If we have a normal sensory integration system, it allows us to respond normally. So therefore, the obvious thing to that is that when we treat the sensory deficits, we allow the child to get to respond more and more normally. Okay? And that's really our end goal. How can we get their output to be better by getting their input to be better? All right. And that's what's really commonly referred to as sensory integration. The dysfunction is called sensory integration dysfunction, or SPD. Not known to be a diagnosis on its own. However, it's usually linked to autism or some kind of learning problem. And so the two usually come together. All right. So you have this sensory integration dysfunction, and we want to do sensory integration treatment. Okay. So how do we treat it? All right. So basically, the simple way to say that we treat it, and perhaps we have to do a part two, is to say that we need to first identify what we think is a problem with the child. Is it visual, auditory? Is it taste and gustatory? Is it the smell? And if those are the things that are being interrupted, is it their proprioceptive systems, their vestibular system? So there are ways to test that. And after testing that, we then want to treat the specific area. All right. So let's just take an easy one like touch. Every time they touch something, they're tactile defensive. They don't want it on their hands. They cry. They need to wash their hands immediately, or they just won't touch it. So, of course, the treatment for that would be submersion in it gently, a little bit at a time, and try to get their defensiveness down. Right. Same with vision. You can do a lot of vision therapy. Again, that's a field entirely onto its own. However, there are eye games and little eye treatment books that you can buy that teach you how to like swing a ball in front of their eyes and have them track and have things come directly to their nose and come away. So there's a whole range of eye and vision exercises that you can do to desensitize the vision. You'll see them squint or look sideways at you. So you really want to get them, desensitized so that they can give you that direct eye contact. Eye contact is partially behavior, mind you. And you really don't sit in front of a child and say, look at me. However, if you're doing indirect treatment around the vision, then you'll start to get better eye contact and connectivity. All right. And it's the same with the taste. This affects the children that have eating disorders. And again, we have to desensitize them very, very carefully. We don't force feed. We get them to play in the food and get used to the food. And then we touch on the tongue. And, distract. You might get something in his mouth, but then turn on the tablet very quickly because guess what? They're so busy focusing on the tablet, they don't even realize. And you can actually hear them going, nyum, 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 but they really couldn't take the spoon into their mouth. You can also do a lot of vibration and desensitization to the mouth so that they can receive a spoon. And a lot of times I start with a fudge stick. That's just less offensive for them. And we get a little bit of food on the edge of the fudge stick, and then we build up to a spoon, right? And now, when it comes to the proprioceptive system for treatment, that has a lot more to do with just heavy work on the body. So basically, we know that, as we said, that there is this disconnect about, what their joints and ligaments are saying and what actually goes up to the brain. Therefore, the more that we pound on the system and the more that we get the system acclimatized to the deep pressure and to, the feedback to the brain that something is pounding on my muscles and ligaments and tendons, right? Then the more that the brain can register, oh, I see, your knees are connected to your toes, that kind of get you that kind of song. Knees are connected to the whatever bone. But basically, the more that you do it is the more that the brain receives the connectivity, okay? And that's not to say that it's really like a one fit for all. You just jump them around the place and put pressure on them. Not really. There's different degrees and different levels when the child is, as to where the child is. So like a modulation child, a very young child who's just beginning treatment, you want to do a lot of heavy work and movement and pressure and deep pressure and, and really get his body moving and responding, especially if it's a very hyper child. And then as time goes by, that proprioception could be something as subtle as heel to toe walking on a board so that he has to feel what his body is really doing in space. And a lot of times we blindfold so that the child can't use their vision to compensate. So now they're not seeing, and they have to totally use their proprioceptive systems and their vestibular systems to keep them walking along that plank. So it's not totally a one fit all and you jump on the plank and you jump up and down and get proprioceptive feedback. However, certainly when you get started with autism, you usually end up with some heavy proprioceptive work and then tune it down into more discriminative work, right? More discrimination of feeling. Okay. So what can we do for proprioception? We can do bear walks and bunny hops, and we can hang from swings, and we can jump up and down on trampolines. We can kick balls, just any of the rough and tough stuff. If you have a mattress, daddy or mommy can throw the child on the bed because you want the whole body to feel pounded, and and you play this game where you run and jump on the bed so that you get that total body proprioception. You can also do joint compression. It's a particular compression of the joints, and perhaps I can be shown how to put up some of that information at one point, where you actually compress, if you can see here. Sorry, let me get this right. I need OT. Here we go. Where am I? Right, where you actually are, this is backwards. So you're actually compressing the joint so that the proximal joint, I'm compressing here, but this joint is going to feel it and send the message to the brain. And then I will compress here and this joint will feel it. You actually need two hands. You compress at the elbow, at the elbow and the wrist so that you get this total compression going through the joints. You start at the fingers, you do the elbows, you do the shoulders. I mean, it's to be done properly. And this, you line up the joint and then you send the message to the brain through a pumping action that this is all connected, knee bone connected to the ankle bone, that thing. Okay. And you don't need a lot of equipment. So you see these fancy occupational therapy gyms, and yeah, they're helpful, but you can have a ball and you bounce the child over the ball. Sit the child up, align their body and just bounce, or you can lie them down and just put pressure through their body. As I said, simple bear hops, wheelbarrow, where they walk like a wheelbarrow and you hold their legs, hanging from any surface, as I said before, just rolling on the ground, letting their body get total impact, right? And then you also have, so have I described heavy work? You can push things, pull things, put somebody in a chair and have them drag it. You could put tennis balls on the bottom of a chair, and the parent sits on the chair and the child has to push the chair, but the tennis balls ease the friction on the floor. That's what I mean by heavy work. You need the child to work so that their muscles and joints and ligaments are engaged and send the message to the brain. And how often? Well, I would love to see that happen, 15 minutes, 4 times a day. You're at school, you just get up and you do some bounces, you go on the playground, you engage a child for 10, 15 minutes proprioceptively, and then you sit him back in his chair, put a little deep pressure on their shoulders, and it usually helps a lot to just regroup them and refocus them. Okay? So, have I answered what do we mean by heavy work? And I'll come back I'll come back when I get an answer. And the next system to talk about is the vestibular system. And again, when the vestibular system is out of whack, right? That is where we see a lot of anxiety and distress when the child's feet leave the ground. They go on the playground, they're very uncomfortable. You lift them up in the air and they're screaming, they're very, very uncomfortable with it. Or the opposite could happen where they crave it and they're not safe. They're climbing the grills, they're jumping over banisters, they're just very, very unsafe because their vestibular system is out of whack and they're seeking movement, right? And this is why it's also very important to put sensory information into the body to reduce their need to seek it. Because if they're going to seek it, they're going to be busy. They're going to be out of control, left, right, moving. Their body is seeking it. So the more that you put it into their body is the less that they need to seek it. Okay. You could also do the opposite thought of that. If you think of a child in a in an orphanage in Europe. I won't call any countries, but we have some horror stories coming out of Europe with children in orphanages, and they're lying on their back, so they really are not getting that proprioceptive input, and they're definitely not getting the vestibular input, and they're not getting eye body coordination. So the studies that are coming out of situations where children are not given tummy time for their eyes to look up and look down and look around, the studies coming out of that are definite dyslexia and learning disabilities, and all kinds of visual processing and visual integration issues with handwriting, etc. Because they've really never integrated their senses between the eyes and the hand, and the eyes and the body, and the eyes and the environment, and your body in space. So if you take a child that's been in an orphanage and they have not had vestibular, they're just lying there. They have not had the work on their inner ear and the movement, and they will definitely have all kinds of issues, which then relates back to learning and school and all kinds of other functionalities. Okay. So these children are scared of movement, or they're very disorganized and always seeking movement, and they're very risky. So they always say, oh my God, he's not afraid of anything. And it's really that his vestibular system just doesn't tell the brain, hey, this isn't wise, right? So the vestibular system, when impaired, can actually be quite dangerous, right? So how do we fix the vestibular system? Well, again, I'm going to give you the general. However, after assessment, we often as clinicians get a little more specific. However, a lot of the general work is fine too. So let us say that we assess them and we realize that they are, really impaired or whatever, have these problems. We typically want to spin them. We want to swing them on different planes. So the inner ear has this plane, horizontal, the vertical plane, and the transducial plane. Sorry, I can't remember the exact word. And those three planes are the three planes of gravity and alignment. So when I put my head like this, my brain tells me my head is not right. And then that same plane that I spoke about is going to tell me, okay, put your head this way. And then that's going to line me up. And this is a good exercise because this mirror is actually back ways for me. So it's like, I feel like my vestibular system is impaired. And so when the three planes are not given the chance, like a child in an orphanage, to integrate and to move about, you're going to have these problems. And so to treat it, we want to move the body on the different planes. So we might swing sideways, front and back, shake them up. We might turn them, again, that word, but anyway, horizontally, 3/4 way over, but not the whole way over. And you're constantly trying to move the brain into the different positions, because what will happen is that the cilia in the inner ear will be put out of place, and then when they're put out of place, they send the message to the brain. That's little hair follicles in the ear, sends a message to the brain, hey, you need to straighten up. And for the orphanage children, they never get that message, so they never really get the how to straighten up, so therefore they have the problems. And I use them as an example, as an extreme example of how our children end up having problems. Now, of course, with an autistic child, they're moving about, they're getting vestibular work, but it's impaired. And by the more that you line them up, is the better you see the child become. And the child will be calmer in no time. So again, the parent that's saying to me, what are we doing in the gym? I'm paying all this money and they're swinging, But you soon see the child calm down and be able to focus better. So this vestibular system is critical to being calm and to be contain their body. And as they get better, again, we get a little more specific with treatment. So we might say we only want them to be swung in a linear fashion because they're calm, but they're disorganized. So swinging in a linear, rhythmic fashion helps them to line up and get a little more organized. And then we could be swinging in a linear fashion and they're getting better and better. And then we could shake them up because that's the child that's like, they hate the change in routine. And it actually comes back to the vestibular system. And when we shake up the vestibular system, unbeknownst to the child, we're trying to shake up his black and white thinking. Okay, so the vestibular system will help us to get these children to overcome some of their rigidity and black and white thinking, anxiety. It just leads back to so many areas. The vestibular system is also connected to the vagus nerve. And again, we could talk on different levels of this condition, but that also connects straight up to the cortex, or just behind, sorry. And then that gives us all kinds of misinformation if not properly integrated. Okay. And what we typically speak about is a sensory diet. So you have this busy child, and every day you're going to do some exercises on the five senses, and especially the other two senses. And you really want to try to do that every day, 20 minutes a day, 30 minutes a day, or 30 minutes twice a day, or 15 minutes four times a day. And try to really be disciplined about it, especially before bed, because you might get a lot of calming before bed, which would also be important, right? So we call that a sensory diet, and you just write your schedule out. At 7:30 in the morning before school, I'm going to do this. Then when he's at school, I'm going to ask the teacher to do this just after lunch. And you try and get your 15-minute segments in. Okay. Just a small example, you have a child who cries and screams, is often kind of freaked out a lot of the time. Slow linear movements, rocking in a chair at school, putting him on your knee and just swinging him slightly left and right. Deep pressure to the body, down on the shoulders, and also pressure garments like vests that have weights in them, or lap blankets that can go on their lap or around their shoulder. These are things that are very calming for the kids. Heavy blankets at night. And so that's just an example of a child who's very hyperactive and his vestibular and proprioceptive systems are out. And we do a lot of calming work that way, especially before bedtime. Right. So just a few not to do's. First of all, you have to, it all really does come down to the assessment. So if you have a very, very busy child, you do a lot of heavy work and then afterwards you follow it with some deep pressure. You don't want to just hype him up, especially before bed, and then say, "Yay, I did my proprioceptive work and my vestibular work and spun him," and then leave him. So after you've done that heavy work, you do want to give him some proprioception, but only in a calming proprioception, meaning same that we want pressure through the joints and the ligaments, right, through the shoulders and the head, but not in a very active way, in a passive way. Okay. Another thing that is a no-no is light brushing to the skin. If you're sitting with anyone and they can just touch you, you close your eyes and they touch you as light as possible. It's a very eerie feeling in that, and what it comes from is that the brain, the light touch are things like ants and bees landing on you, or the other thing is that light touch, you don't know what's touching you. So it just feels very uncomfortable when somebody comes up by surprise and touches you like that. But if you give them a nice, deep, firm hold, that gives them security. They know where that touch is coming from. They can even identify what the touch is because it's more pressure, and they can go, "Oh, I feel 4 fingers and a thumb." So we really recommend deep pressure, not that light, tickly touch. So be very careful about that. There are specific exercises that you can do with brushing using a therapy brush. And it should be that therapy brush, but if you don't have that, you can always use like a baby brush. But remember, we're not doing that tickly thing. So you put a little brisky pressure on that brush. This is called there's the brushing, and then the Wilbarger's brushing system, and there's also the deep pressure system where I told you before about the joint compression. Again, if you look online, deep pressure and Wilbarger's brushing, you will be able to see online the techniques that are used, all right? Or if there's anything I can be able to provide and upload somewhere, I'd be happy to. And that gives you the protocol of how to brush and how to do the deep pressure, right? So the brushing is also very, very good for proprioceptive feedback, because wherever you have the brush and you put pressure on it, it's telling the brain, "Oh, right, I'm connecting all the time to my body," all right? And we do recommend the brushing at least twice a day. Again, 20 minutes twice a day. So you can just do your whole sensory package to include the brushing, the deep pressure, the proprioception, and if you can, some vision and hearing exercises. Hearing exercises, even things like give me the ball that's red. And that's why I think ABA is a very effective tool, because it's constantly bombarding the hearing system. And once the child starts to hear, I mean, they always heard, but hear through the nerves and process to the brain, you actually get a child that calms right down because they're no longer in this world of just, confusion. So the ears are a huge gateway to their responsiveness. All right. So even just bombarding things like give me this, go get that, and it's constant, and you're really pressuring them to listen to you and hear you. Once the ears start to process, you get a different child, just that alone. So you want to do a lot of work on the ears, listening to music, mostly Mozart. There are different listening systems on the internet that you can purchase. Some of them are kind of generic and kind of cheaper, but that's okay. They can work. And you want to do a lot of work with their eyes, teaming, where the two eyes come together. Again, you'll have to look up vision exercises, or I can post. And you definitely want to do your proprioception and your vestibular, and your brushing and your deep touch. Okay. So I haven't seen too many questions. I'm wondering if this would be a good time to ask if anyone has any questions. I think it takes a little while for the typed messages to come through. Here we go. So, what do we do if a child is walking on his toes? All right, great question. Okay, so there are a few theories about the integration of reflexes in the body. All right, and one of those theories is that if all right, we're all born with reflex reactions. So, for example, we come down the birth canal using an see if I can see myself here using an ATNR posture. So this arm comes down the birth canal, and this arm and body follows, and we dive down through the birth canal. So when we come out of the birth canal, we our senses are then not integrated. We're still in an ATNR position. So every time you go near to the child, you'll see the child kind of doing something like this with his head. Okay. And within a few weeks, I don't have the chart in front of me, but within a certain short time, your body integrates and you no longer have that reflex. Okay. You only needed that reflex to get down the birth canal. And then there's like the rooting canal, where you touch here and the child mouth will come to your finger. And that's for feeding. That's a feeding reflex. So, of course, they need to touch. They feel that. They feel the breast or the nipple bottle, and they respond immediately so that they can take milk. Okay? So, those are reflexes. So, one of the techniques that we use here at Therapy Plus is that we work on the foot using reflex inhibitions, because we feel that maybe there's retained reflexes in some areas, and we use specific reflex, well, it's not reflexology, but it's reflex patterns to try to get the child out of that primitive reflex so that they no longer want to toe walk. The other thing we do is not very much. And why I say that is by working on their vestibular and proprioceptive systems, I would say 80% of more, maybe 90% of my toe walkers stop toe walking. Okay. But there are chronic toe walkers that it just continues no matter how much foot reflexes we do, no matter how much proprioception and vestibular, no matter how much verbal cueing. We put weights on the ankles. And no matter what we do, the child, in fact, weights on the ankles is good and bad because, yes, sometimes we keep them down, which is great. And then they get a new way of what it feels like. But the other problem with it is sometimes they burst through that and they are on their toes against gravity and against the weights. And therefore, they're getting stronger and better at toe walking. So we have to gauge that carefully. And for the kids that really won't come out of it, we splint them. So we put what we call AFOs on their feet and special wider shoes, and they're in those 24 hours a day. And you see a reduction, but not necessarily a fixing of it. But you definitely see like an 80% reduction in the toe walking when they're chronic and they are splinted. But really early intervention and a lot of vestibular and proprioceptive work and some work to the feet usually does clear it up, maybe 90% of the cases. But remember that all of that vestibular and proprioceptive system dysregulation, once that starts to line up better, the toe walking just automatically goes away. Is there a sensory issue for a child that bangs his head? Yeah, so head banging is definitely a sensory issue. It can become a behavioral issue also, where he finds that he gets enough attention for head banging. But initially, sensory, I shouldn't say, it, I would say most of the cases are sensory, okay? And they certainly start out as sensory, but then can develop into straight behavior. And so, and a combination of both, right? Again, in the last 6 months, I've had three headbangers, and I've had my finger on the dial to order a helmet, and I haven't had to. Right? We start the vestibular work, the proprioceptive work. I mean, we do over 100 hours of therapy here a week. So guess what? I then forget about that kid having a headbanging problem. I mean, if it was bad, the therapist would come to me, but I don't even focus on it, mostly due to time, unless it's something very dangerous. And then all of a sudden, you realize that they're not headbanging anymore. And you ask the therapist, and she goes, "Oh, no, 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 he stopped." Of course, if it proceeded and it was dangerous, it would be brought to my attention and I would get him a helmet. And my finger is always ready to press that helmet button because headbanging is not a good thing. However, 90% of the time, I'm not even thinking about it, it goes away. All right. Once we start therapy, within 2 to 3 weeks, we usually don't see headbanging. There are chronic cases. And remember, I'm really talking about the child that I take young. So I really don't usually take older children. They usually don't really even apply to the center. But let's say you've been headbanging for 8 years. I don't tell you that the fix would be that easy. But once they are young and they start to have some means of communication, so they're not as frustrated, and the ABA is working, and the vestibular and the proprioceptive systems are kicking in, then it actually literally just goes away. So mouthing, it says, the question is, how can you stop a child from putting everything in their mouth? So mouthing, again, depends how long it's been going on, right? So I'm going to take it from the baby stage. So once I get a child, most of them are mouthing, mostly because developmentally they're very young. They're doing what babies do. And the mouth is the most sensitive and receptive part of the body for giving the brain information about what things are. So you put something in your mouth, you get the texture, you get the feel, you even get the image. And baby's mouth up until, I forget how many months, maybe 5 or 6 or 7 months. And this thing could also be, once again, one of those retained reflexes, and we can do reflex work for the mouth. Again, you have to be a bit trained in the reflex work, but so it can be part of a retained reflex, but it also can be, and usually more likely is, exploration of their world through their mouth. And so once you start getting that child to not be so tactile defensive and to really use their hands, once again, it's one of those things that really just start to disappear if you have a lot of intensive therapy to the hands. And I mean really intensive. So, 30 minutes a day, putty, taking out pegs, putting puzzle pieces in. And every time they go to the mouth, you gently block, and you just keep the hands engaged as much as possible. A lot of deep pressure to the hands being submerged in different textures and what do you call it? Just different feeling of things, rub things on their hand surface, right? And then what will happen is that it will transfer from the mouth needing to explore down to the hands exploring. Okay. If it's years and years old and it's chronic, then you probably have to look at a lot more blocking. And that's a lot of intense work, meaning you've got to be there with the child, you've got to block, 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 and then replace it with something else. So again, give them something for their hands. Or if you feel that the satisfaction comes from the mouth, having something in their mouth, you could put something a little more appropriate in their mouth, like a chew stick or something else that might give them some gratification other than objects, right? So every time they go to put an object in their mouth, you block it and you replace it with the chew stick, which could be hanging on to their shirt by a pin or something, and they lift it up and put it in their mouth. Okay. And hopefully too, when they feel the need to put something in their mouth, they might just automatically go for the chewer instead of the object. Okay. My son is a headbanger. He is 6. Are there specific methods I can use to help him? He is both sensory and behavioral. Okay, right. So he's 6 years old. I'll ask a question, I'll keep talking, and then you can respond. Does he communicate? So the main fixer for the head banging outside of sensory and why it becomes behavioral is just two things. One, not being able to communicate and get the message across to what he needs. So therefore it's a type of tantrum. And two, is the, as I going to say, outside of sensory. So he's banging and he is, right, for attention, sorry, either for attention or because he can't talk. So if it is that he can't talk, you've got to find a means of communication as soon as possible, okay? And that doesn't have to be verbal. He can use PECs, pictures, picture exchange systems. And if you really can't do PECs as perfectly as you would like to, then even just a picture on a chart with a little Velcro and says, I need juice, or I want my tablet, or what have you. Now, the other issue with the head banging is it can be for attention, and often, most times, it's because you take something from him, or he's upset that he didn't get his way. And that's where the behavior comes in, whether attention or not getting his own way. Well, usually the attention is fed off of not getting his own way. Therefore, that takes behavior therapy. So therefore, you need to go through a whole rigorous routine of take it away and count him down. So 3, 2, 1, and give back the object. And then you stretch that counting to 10, 15, and give back the object. Okay. So therefore, what he's learning to do is that he can wait. Things can be taken away from him. Your turn, my turn. I'm not going to die over this. I can actually share. I can actually wait. And you have to do a lot of good training in that every single day until he learns to trust that, okay, I don't have to freak out every time I don't get my own way. So I hope I'm not going too fast there, but basically you have to train him to wait. You have to train him to learn to lose things. And you also have to address the sensory things at the same time, the vestibular, the probe, and for sure, he needs communication, right? So those 3 things have to be in place. And then the next thing that needs to be in place is perhaps then you have to get a helmet, because 1, it's dangerous. And 2, my findings with the helmet is the whole role switches and the helmet becomes aversive. Now, what do I mean by that? So at first, I'm just trying to protect the kid's head, right? And then it becomes, don't put that on my head, don't put that, or no, 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 and they're moving away. And then you say, even if they can't communicate, and then you say, all right, well, if you bang your head, I have to put it on. And so you'll see them kind of make to do it. And even if they make to do it, you pick up that helmet and you say, you tried to bang your head, and you get it on their head. So in other words, eventually they realize I can't even do this because I'm going to get the helmet on my head. So it actually flips around and becomes aversive many times. And that works in its own way, even though we don't really want to use punishment and aversiveness generally, but it happens to just work all on its own that way. Okay. So yes, you replied there that you believe it's more behavior. So I think I've kind of covered that. What you want to also do is record which things trigger that behavior. So if it's like removal of a tablet, then you're going to give him a lot of warning. You give him a picture schedule so he knows it's after tablet time, it's bath time every single day. You keep his routine so that he understands that, I'm not going to get as upset because every day this is what happens, so I can cope with it a little better. Really need those picture schedules, really need those routines and the boundaries. And the other thing is, guys, whatever is driving that headbanging, that obsession, whatever it is that you can't take from him, it needs to be removed out of his life. And you'd be really, really surprised. It could be cars, it could be a tablet, of course. But the less that you give them these things and allow the obsession on these things is the less that those behaviors exist. A lot of parents come in and I'm like, I'm sorry, but all the cars have to go. And they're like, are you kidding me? He loves cars and we've bought 100 cars. And not only that, he would just freak out. So what we tell them to do is reduce the cars down to like 5 cars and then 4 and then 3 and then cold turkey. It's imperative. So basically headbanging is a function of some kind of obsessional behavior where they're not getting what they want and they become obsessional over the thing. And then that makes the headbanging worse. So to get rid of obsessions, you get rid of the item, right? And ironically, in 2 to 3 weeks, when you reintroduce that item, you can remove it from them. That's the weirdest thing. Like in 2 or 3 weeks, you'll realize the same item that he was so crazy about, I got rid of it and it's much better. All right. And that can be letters, numbers, transportation, whatever it is they're obsessing on. Okay. Something is blocking it here. I'm afraid to click this. Hang on. Let's see. Oops. My 5-year-old absolutely hates getting his hair cut. It's such an overwhelming experience. Right. And I wonder if that's with a shear or with the scissors. So they can't stand the sound of the shear, right? And You know what? To be honest with you, I mean, as a therapist, I'm not a hairdresser, so therefore, I'm not with the child while they're getting their hair done. However, it comes together when they're about 8 or 9. However, that's just by keeping going, and everybody has to hold him down in the chair, and it's torturous, right? Um, Unfortunately, they have systems in their brain that really trigger and really chip in when you try to do something aversive to them. Like they feel like they're dying. I mean, it's as if somebody really held you down and had a knife to your throat. Literally, that's how it feels for them. So the feeling is very, very real. So we want to be sensitive about it instead of this hold him down and keep cutting his hair till he's 8 and he gets used to it. That's a rough way. So one of the best things is really to use a scissors, so you don't have that zzz in his hair. And the other way to do it is to desensitize him slowly. All right. So for example, you could watch it on a video, then you could have him touch it. You could have him cut off a piece of his own hair and see that it's not that bad. And you slowly, slowly do it. Right. It's very rough though, guys. I know, between the hair cutting and the teeth cleaning and the dentist. And once they've had an injection, that fair thing, it's amyloid organ. And once that kicks in, oh my goodness, they're just like they feel as if they're going to die, literally. So it's very, very hard to break and desensitize that, but you've got to just keep doing it little by little. Give him the scissors, let him be in control. Here, you do it, now I'll do a little piece, and you see if you can kind of play around with it a little bit. Give him the scissors to hold, show him the videos about people cutting their hair. Cut a piece of your hair, and really desensitizing, right? I've had the funkiest of haircuts through my life here. Like, all haircuts are a hilarious standard here, where the parents said I couldn't take it anymore. Daddy held him and I just cut it. But try to do it in the most gentle way, because it really, really feels like world's end for them. Yeah, the sound and the vibration is definitely a big problem. So using the shares is really rough on them, right? And what you can do is always have the share at home. Buy a cheap pair of shares. I call them shares. I'm not sure what they're really called. And you turn it on and let him feel the vibration and touch it, and let him shave off the doll's. Buy a doll and let him shave the doll's hair. Take a longer piece of his hair and you hold it with him and let him share that and show him the hair. And over time, you can desensitize so that eventually you can get to use that, because that's, of course, a much easier way for cutting hair. And then culturally, I'm not sure what kind of hair, if the hair is amenable to being cut with the scissors. If not, then of course the picture gets a little more difficult. Definitely do a lot of buzz cuts if you do get the opportunity, so that you don't have to go back too soon to the hairdresser, to the barber. And again, working on those vestibular systems, desensitizing to all kinds of different sounds and stuff, and vibration and touch. You can even put vibration in the head. Those things can help by, just the vestibular and the probe and the deep pressure and the touch and the vibration. Those things can help to desensitize the child for future things like hair cutting. I missed a question. Okay. Do you recommend mixing techniques with hearing along with visuals? Yes. I find my son sometimes reacts better to visual instructions as opposed to verbal. Okay, great question. So initially, you might train visual only. And okay, that's kind of a complex question. It's a great question. So, all right, typically our children are more visual than auditory if they're on the spectrum. All right. And therefore, you can use visual cues to get a lot of learning in, to get to all the things that you need. Obviously, you will see their strength come out visually. All right. And therefore, you're going to use it, which is very understandable. The problem is that the more you drive the visual side is the more you stunt the auditory side. And therefore, you can use your visual because he's going to use it anyway. But there are times where you want to occlude the visual. So you want to do a lot of auditory processing, a lot of work on the ears, music, and keep the eyes out of it. So, for example, I mentioned earlier that as I try to get more proprioceptive skill into a child, I'll cover their eyes. And that's because they use vision all the time to compensate. They're not really balancing. They're using their eyes to balance, okay? And it's the same with this. You want to really limit the visual and increase the auditory so that the two can balance. When they're getting even better now, then you can do visual and auditory at the same time, where I mentioned earlier, you call them and they turn their eyes to you and turn their ear to orient to the sound, right? And you can do metronomes and you can do eye-hand coordination with drumming while you're also hearing the beat and keeping the time. And so there's a range of exercises where you coordinate the eyes with the ears. You can do comprehensions if they're at that stage where you read the answer. You read the question, but then you also cover up the next question and ask them auditorily. So you're always doing auditory with the visual. All right. You're doing that from the onset, and then as you get better, you actually mix the visual with the auditory. Okay, try and think of another example. Okay, so for example, it's highly recommended that you use the listening machine. All right, there's Paul Mado, and there is, well, if you look up the original Tomatis, you will see that the this auditory listening system is originally was used just with the ears, and then as time went by, they realized that if they combine that with the proprioceptive and vestibular, they actually get better results. And again, you could use that with coloring or filling in, you know, little complex coloring that you do while you're actually listening to the headphones. So they're trying to get you to coordinate your vision with your hearing, with your eye-hand coordination, all of it happening at the same time. I know there's a bit of a delay when people ask questions, so wait a second. All right, so I'm not seeing any more questions. I hope you enjoyed this. Thanks very much to Christy Almeida for hosting, allowing me to talk on this topic. I'm here in Jamaica, but we're Caribbean in spirit, right? And I hope you stay safe during COVID. And, hopefully we'll have the opportunity to meet again. Christy, if you want to. All right. So thanks all for attending. Thanks. I'm available if I can help in any way, through information, techniques, whatever. So we'll be in touch through Christy, I'm sure, and we will take it from there. Okay. So bye, folks. Thanks a lot.